Okay, we're going to do what are you going to do? Oh yeah, shoulder dystocia. So what happens in but basically shoulder dystocia is basically the definition is it's an obstetric emergency when you're delivering someone uh, in cephalic vaginal delivery where when you're doing genital traction you fail to deliver the shoulders after the head has been delivered, requiring additional obstetric maneuvers. So the reason is there are risk factors for you to develop shoulder dystocia. One is there can be obesity, and then if you have previous dystocia, that's also a risk. And then if you have a contracted small pelvis, that is also a risk. If you have diabetes mellitus during the pregnancy, that is also a risk. And then delayed first stage, instrumental delivery, oxytocin augmentation, and because of this, you can develop complications when you're delivering a patient with shoulder dystocia. Example, you can get brachial plexus damage in the child, cervical spine injury, and then clavicular fractures can occur. And then you can also get hypoxic ischemic encephalopathy as well. So the diagnosis is when you suspect shoulder dystocia is when there's delivery with axial traction, and there is this sign known as a turtle sign where the head comes out and goes in when you stop straining. So when it comes out during straining and disappears when the mother stops straining. And that is known as a turtle sign,
head
like our
bobbing, right?
turtles. Someone spoke?
What you said that was head bobbing, right? Not turtle neck, right?
Turtle sign.
Turtle sign is when the head is outside the perineum.
Yeah, it comes out and goes in.
No, that is head bobbing. Head bobbing is when when you're contracting, head comes to the introitus and it goes back. With maternal push, it comes to introitus and goes back with contraction. Turtleneck is where the head is outside the perineum, but it goes towards the perineum tightly.
Where did he say this?
Deepa's book.
Okay. I thought it like head comes out and disappears when it strains.
We had a class on shoulder dystocia in Navisavella, and they told what you told, Kavi.
Yeah, so in Google also it says that it goes in like a turtle. Anyways, then this is not just call it turtle sign, just it goes out and in. So yeah. So now like if a patient comes with this suspected shoulder dystocia, you have to know how to manage. So it's a bit difficult to understand, but I also can't understand it properly, but I just try and draw it. So it's easier to make sense of it. Enable screen share. Can you see the whiteboard?
Yeah, bro.
Okay, so what happens is, let's say this is the pelvis, and then so these like the pubic symphysis. I put as PS, and then someone sent me a message. And this is the sacrum. So what will happen is either the baby's shoulder can get dislodged, like blocked by the pubic symphysis, or else sometimes in very rare cases it can get impacted in the sacral promontory, right about here. So so if there is a block in the birth canal, what you can do is your option is either increase the size of the birth canal by doing certain maneuvers, or reduce the biacromial diameter, that is the distance between the two shoulders. So for do that there are special maneuvers. So the first maneuver, when the patient comes with suspected shoulder dystocia, so when do you suspect shoulder dystocia is when you apply traction, the child does not come out. So the first thing is when you have a patient, you immediately call for help, because you need multiple people to manage this patient. And then you tell the patient as well that probably the patient's child shoulder is stuck in the pubic symphysis, and then you ask the patient not to strain, and you stop giving Synto, as this can worsen the condition, and you don't pull the baby immediately. So, like I said, the goal is to increase the pelvic diameter and the biacromial diameter by flexing the shoulder. So, reason you get this blockage is because the anterior posterior diameter in the pelvis is small. So, you know about the pelvic inlet. In the pelvic inlet, this diameter is small, but the transverse diameter is wider. And in the pelvic outlet, it's the opposite. This time, the anterior posterior diameter is wider, but the transverse diameter is smaller. So the first maneuver you do is known as the McRoberts position. Okay, can you guys hear me?
Yeah, we can hear you.
Yeah, so McRoberts position. So let's say this is the mom, and these are the legs. You have to properly flex the legs and make sure that the back, that the sacral dimplum is coming out of the bed. Like you have to flex up to the point where it touches the mother's abdomen, and basically you have to flex and abduct the legs. Okay, so he's like the mother. So you have to flex and abduct the legs. These are the legs. It's a very bad drawing, but he's the head. Okay. Okay, so you basically flex the uh, hip joint, and you need one person for each leg. So one leg is by one nurse who will like lift it, and the other leg is by another nurse. So when you do this macropause position, this would increase the size of the anterior-posterior diameter. Okay, so usually when you do this maneuver, most of the time it will be successful and the baby would come out. But then if that fails, then you can apply suprapubic pressure. Okay, so what you do first is you put the patient in the macrobert position by flexing the hip, and then you can give suprapubic pressure. So now let's say this is the pubic symphysis, and then this is the baby, and then these the baby's shoulders, and then
Okay,
these
sorry,
the
can
yeah.
everyone see the screen or is it black only for me?
Hello,
Hello?
I don't know. Can anyone see the screen?
I can see the screen. Can others see the screen?
I also can see.
Okay, then my bad. Sorry.
Yeah. So these the was it like this before also? Yesterday also you couldn't see, no?
Yeah, man, my phone is a bit weird these days.
Yeah. Okay, so this is the pubic symphysis, and then this is the sacrum, and so I'm going to draw the baby. So this is the baby's head, and then these are the shoulders. Okay, shoulder. So what you do is first you put the patient in the macrobird position where you lift the mother's legs up uh, by flexing the hip, and then you apply suprapubic pressure. You tell someone to apply suprapubic pressure. So that is, you tell them to you make like a fist or something, or apply pressure with their hand like this to push the shoulder downwards. Okay, and when you push the shoulder downwards, then the baby would come out. So that is the next thing you do. So first you call for help, then you flex the hips and the thigh, and then you apply suprapubic pressure to turn the baby. So now after that, most of the time the baby would deliver. Then the next thing is these are known as the external maneuvers. So after you do the external maneuvers, you have to do the internal maneuvers if it's not successful. Hello, can you hear me?
Now can hear.
Something happened. Where did I stop?
You were still explaining the macrobots maneuver.
Yeah, so macrovasectomy basically you lift the mother's legs up and then you apply suprapubic pressure, and these are known as the external maneuvers. And then after external maneuvers is the internal maneuvers. So internal maneuvers, they are known as the Rubin's maneuver as well as the wood screw maneuver. It's wood screw and Rubin's maneuver basically the same, except in wood screw you use both your hands, and in Rubin's maneuver you use one hand. So before, what you did is, let's say this is the mother's abdomen, this is the mother's face. You apply pressure from the top to turn the baby. But in this case, let's say this is the mother's birth canal. This is the head. What you would do in this Rubin's maneuver is where you would put one of your hands into the vagina. Okay? And you put one of your hands into the vagina, and then you would like turn the baby to the oblique position and pull the baby out. So that is the Rubin's maneuver. And then after that, there is the wood screw maneuver where you use both your hands to turn the baby. One in the anterior shoulder and one in the posterior shoulder. And then lastly is this position known as the all fours position. So where you keep the mom in all fours. And with the help of gravity, the baby would be delivered. So after that, if all fails, then there is the third option where you can do this special maneuver known as a Zavanelli maneuver, where you push the child back into the vagina and do a C-section, or else you can do a symphysiotomy where you cut the pubic symphysis fibers to make more space, and then you can also fracture the baby's clavicle. So there is a mnemonic to help with all these maneuvers. So it's known as ELAMA. So ELAMA, first thing you do is A is to ask for help, and then L is to legs to hyperflex, which is basically the macroburst maneuver, and A is to apply suprapubic pressure, and as well as Rubin's maneuver. And then there is another thing we can do is you can also release the posterior shoulder. And lastly, M is the maneuver of Woods, called the Woods maneuver. And E is epiphysiotomy. And A is roll on all fours. So basically, that's about shoulder dystocia. Did I miss anything? Yeah. Did I miss anything? Hello? Hello?
No, that's it.
Yeah. And then we can do one more. Yeah, what else? We can do acute inversion of the uterus quickly as well. So, like, how would a patient with acute inversion of the uterus present is? I quickly give a case scenario. So, 21-year-old mother of one in a third pregnancy. Second pregnancy was a miscarriage where surgical management was done, and it was complicated with uterine perforation. Third pregnancy antenatal was uncomplicated, and she was admitted with labor and delivered baby without any prolongation. Third stage of labor was prolonged and placenta was delivered by manual removal. After removal, the patient was drowsy and thirsty, and the GCS is 14, and she is dyspneic with a respiratory rate of 24, blood pressure is 80/40, and pulse rate is 70. So how do you manage this as extra? So I'll tell it again. 29-year-old mother, third pregnancy. He had history of miscarriage before, and third stage was prolonged, and the placenta is delivered by manual removal. Currently, a GCS is 14. She's a bit drowsy. Respiratory rate is 24, which is high. Blood pressure is 80/40, and pulse rate is 70. How would you manage? So, does anyone know? Hello. Hello. Sudu. Shivani?
No idea, dude.
Yeah, so this is when there is low blood pressure, the blood flow to the brain and the heart is decreased. So that's what you can see in this patient. That's why she is drowsy. So when there's hypovolemia, you can get tachycardia, but in the above patient, you have heart rate of 70. Heart rate of 70, which is not hypovolemic. So this is probably a neurogenic shock. This patient is having a neurogenic shock. That's why usually if it's a hypovolemic shock, the heart rate would be increased. But in this case, our pulse rate is 70. This shock is due to the manual removal of the placenta. And yeah, this prolonged third stage of labor in this patient may be due to morbidly laden placenta. So manual removal of placenta usually causes neurogenic shock. So in this emergency, like any emergency, you need to resuscitate by checking the airway, breathing, and circulation. Then you, as always, you call for help, insert two white bore cannulas, reserve blood for grouping DT, and yeah, also in inversion, and you should also give fluids to increase the blood pressure because the blood pressure is low, and you need to give at least a liter of crystalloids. And in inversion also, the uterus has failed to contract, similar to what we did before, where there is uterine atony. In this case, first it has failed to contract. This can also lead to postpartum hemorrhage, so you need to reserve at least 4 pints of blood. The reason you get this shock is due to the overstretching of the ligaments and all of these fallopian tubes. They're all innervated by your vagus nerve. So this is your diagnosis is inversion because you feel like a boggy mass from clinical examination of the uterus. So you get hypertension with bradycardia or an irregular abdomen and disproportionate shock with and clinical signs. So the definite management is you have to restore the uterus back to its normal position. So one thing you can do is since you manually remove the placenta, you can manually put the uterus back to its original position with your hand by creating a fix. Other option is hydrostatic reduction by closing the vagina and you fill the vagina with normal saline. And this would also bring the uterus back to normal. Third stage is you do a surgery by the abdominal route. And so you need to, in this case, relax the uterus by giving short-acting tocolytics like terbutaline, which has a short duration and fast onset of action. Once the fundus is in normal position, then you can start the syntocinon. So the uterus contracts, and then you take the hand out, and this maneuver is known as the Johnson's maneuver. And then the complications of this uterine inversion is you can get perforation when doing these procedures as well as PPH. And then the hydrostatic method, it is time consuming and has a high failure rate. And then there are the surgeries which you do for this is known as a Huntington or Holton procedure. So yeah, so the risk factors is of uterine inversion is there's like short umbilical cord, placenta previa, uterine atony. Those are a few risk factors, and most of them there is no risk factors. And how they present is neurogenic signs, which is bradycardia and hypotension. And then on clinical examination, you feel a lump in the vagina with a tender abdomen. And then on palpation of the abdomen, you might not feel a uterus. Then symptoms, they would have severe abdominal pain. And the DDs of this uterine inversion can be uterine vaginal prolapse or fibroid or a severe uterine atony. And the management is like I told you, you have to call for help, resuscitate, and then first is you use your hand, then you do hydrostatic reduction, and last option is surgery. So yeah, let me say, hello, hello,
Yeah, dude.
yeah. That's about it. We're out of time now. Who's sending the ID for Suranga's
I think
class?
Ocean will send me.
Hey, do you know about code collapse?
Yeah.
And tell you how to manage.
How to manage code collapse.
Yeah.
Okay. So again, I'm not going for the risk factors or anything, but first thing you should do is like, again, call for help and inform seniors. First thing you should do is to try and elevate the presenting part so you can elevate it manually. And you can, especially if it happened after ARM, the other thing you should do is you should avoid excessive handling of the cord, but you can put it back into the vagina. You don't try to push it back into the cervix because that's too much handling. Because one of the two problems are like mechanically the cord being compressed or the cord being like vasospasm due to like cold exposure. So those two things you can do. If you need to keep it for a longer time before doing a more definite treatment, that is, you can do a bladder filling, because bladder filling like to put a catheter, fill it and clamp it. That also helps elevate the presenting part. Then you can put the patient into the modified Sims position. That is basically the left lateral position, but you elevate the like on one leg above. Or you can try the Trendelenburg position, which is like basically the whole bed is like tilted, so the head is near the bottom. Or you can put them into the knee chest position. Better to say knee chest position first because that's the most easiest thing to do. Then I mean, cord prolapse is like fetal distress, so you have to deliver immediately. So if the vagina is like fully dilated, sorry, cervix is fully dilated, and like there's a lot less descent is there beyond station 0, then you can go for forceps delivery. Or if it's not, then you might have to go for emergency C-section. If you really have a big delay, then you can do tocolysis while doing all this bladder filling and knee chest stuff.
Okay. 4K. I will do ectopic and miscarriage some other day. Alright. Bye bye. See you.
Bye.